Hello, my name is Dr. Pascal and this is a video on abdominal examination. This video is going to be divided into three parts. The first part is going to be a concise theory of abdominal examination. The second part is a step-by-step examination of the abdomen, while the third part is going to be a 3-minute OSCE guide. The same way is going to be in your exams. If you're new to our channel, kindly like and subscribe to this channel for more helpful tutorials. Digestive system examination is different from abdominal examination. In digestive system examination, you're starting from the mouth to the anus. But for abdominal examination, we focus on the abdomen, which is the area between the chest and the pelvis. It also extends to involve the digital rectal examination. Abdominal examination, just like every other examination, is used to elicit signs which will help you to make your diagnosis. There are three phases to every exam. We have the pre-exam, we have the exam proper, and we have the post-exam. The pre-exam is where you greet your patient and introduce yourself, explain the procedure and obtain consent. You can also ask your patient to empty their bowel, especially for abdominal examination. Then you ask for a screen, that's for privacy, and call for a chaperone. Then properly position your patient in supine position, exposing patient just from below the nipple line to the pubic symphysis. Then you wash your hand and commence your examination. In post-exam, this is where you thank your patient and summarize your findings. So the pre-exam and the post-exam are essentially the same for all your examination. Then we are going to go over to the exam proper. So in the examination proper, we are going to follow the regular sequence of inspection, palpation, percussion, and auscultation. But before we discuss this sequence, we will look at the 9 regions of the abdomen. The abdomen is divided into 9 regions by 2 vertical lines running along the mid-clavicular planes and 2 horizontal lines, one at the subcostal plane and the other at the transtubercular plane. So we have 9 regions of the abdomen, and these regions include 1. The right hypochondric region, which is located at the upper right under the ribs. It houses the right lobe of the liver, the gallbladder, the upper part of the right kidney, and the hepatic flexure of the colon. Then we also have the epigastric region, which is at the middle, just below the sternum. It houses the left lobe of the liver, the pylorus of the stomach, the first part of the duodenum, and also the body of the pancreas. Then we also have the left hypochondriac region, which is located at the upper left under the ribs. The main organs it contains include the fundus of the stomach, the spleen, the tail of the pancreas, the upper pole of the left kidney, and the splenic flexure of the colon. Then we also have the right lumbar, which we also regard as the flank. So this region is located at the mid-right of the abdomen, and it contains the following: the ascending colon, the lower part of the right kidney, and the small intestinal lobes. Then we have the umbilical region, which is located central around the umbilicus. It contains the transverse colon, the jejunum, and the ileum, and also the lower part of the pancreas. Then we also have the left lumbar, which is located at the mid-left of the abdomen. It contains the descending colon, the lower part of the left kidney, and the small intestine lobes. Then the 7th region is the right iliac region, also known as the right inguinal region. It is located at the lower right of the abdomen, near the groin. It contains the cecum, the appendix, the terminal ileum. In females, it contains the right ovary and the right fallopian tube. Then we have the hypogastric, otherwise called suprapubic region, which is located at the lower middle abdomen, just above the pubic bone. It contains the urinary bladder, the sigmoid colon, the uterus in females, and the small intestinal lobes. Then lastly, we have the left iliac region. The left iliac region is located at the lower left abdomen near the groin. It contains the sigmoid colon, the left ovary, and the fallopian tubes in females. Now, we can use these regions to make our examination easier. So let's move over to the first part, which is inspection. You look before you touch. So for every patient, you're expected to look before you touch. So that is what inspection entails. What are the things you're going to be looking out for? You're going to be looking out for the shape, the symmetry of the abdomen. Is there any scar? Is there any skin lesion? Any swelling? Surface movements? Stretch marks? Movement with respiration? The shape and position of the umbilicus? Is there any distended vein? So we are going to take our time to briefly discuss each of them one after the other. So the shape of the abdomen. The shape of the abdomen can either be flat, scaphoid, or distended. The abdomen can be flat, which you are going to see in most patients. It can also be scaphoid. This is commonly seen in severely malnourished patients. The abdomen can also be distended. Once the abdomen is distended, you're going to categorize any of the causes of the abdominal distension into this category. So it can either be fat, fluid, fetus, flatus, physics, or even a fatal tumor. So after the shape, you're going to look at the symmetry. Is the abdomen symmetrical or asymmetrical? The abdomen is usually symmetrical in most normal patients, but there are situations where the abdomen can also be asymmetrical. For example, in a patient with hepatocellular carcinoma, where the liver has been grossly enlarged, the abdomen is going to be asymmetrical. So you are supposed to look out for the symmetry of the abdomen. Then you go ahead to look out for scars, which might suggest a previous surgery, be it from appendectomy, cesarean section, or exploratory laparotomy. Then you also look at the skin, if there are any lesions such as rashes or bruising. This bruising can come from trauma, as seen in calling or great Turner signs. Then you also look out for any swelling or mass, which may indicate a hernia, a cyst, or a tumor. Then you look out for surface movements. If you're able to see visible peristalsis, which can be seen in intestinal obstruction, especially in children. Then we also have pulsations, which you can also see as a surface movement, and this is found in aortic aneurysm. Then you also check out for stretch marks, which is common in pregnancy or obesity. Other things you are supposed to look out for are movement with respiration. Is the abdomen moving with respiration? If the spleen is enlarged, the abdomen usually moves with respiration, but it can be reduced in peritonitis or in massive ascites. Then you also check out for the umbilicus. The umbilicus can be everted, flat, or retracted. If the umbilicus is everted or protruded, it might suggest ascites or a hernia. If the umbilicus is flat, it's usually normal in most cases. So in most individuals, you're going to see a flat umbilicus. Then you can also have an inverted or a retracted umbilicus, such as the one seen in malnourished patients. Then other things you can also look out for in the abdomen while doing your inspection is a nodule that is hard, irregular, usually found at the umbilicus, and this nodule is called Sister-Mary-Joseph nodule. It indicates a metastatic deposit, which mostly occur from gastric or pancreatic or even an ovarian carcinoma. Then you look out for dilated veins, which is seen in caput medusa, that's in portal hypertension. This usually occurs when blood flow through the liver is blocked, a condition called portal hypertension, and it commonly occurs due to liver cirrhosis. So because blood can't pass easily through the liver, it finds other routes. Then it flows backward through small veins around the abdomen, making them big and visible. Then you can also go ahead to ask your patient to cough. In this way, you're going to check out for any herniations during that cough. Then lastly, we are going to check for abdominal gait. Abdominal gait is the measurement of the circumference of the abdomen. It is usually taken at the level of the umbilicus, but you can also use the xiphostenum as a landmark, where you measure the widest diameter in reference to the distance from the xiphostenum. Abdominal gait is used to assess changes in abdominal distension. One single measurement of abdominal gait may not give a proper information about your patient, but you require a serial monitoring to make a good assessment on your patient. So in that case, abdominal gait can either increase or decrease, which shows the progression of the abdominal distension. So if the abdominal gait is increasing, it actually entails a possible accumulation of fluid in the peritoneal cavity, or abdominal tumor, or even pregnancy. But if the abdominal gait is decreasing in a patient with ascites, it indicates response to treatment. But if you have a rapid increase in abdominal gait, it might suggest rapid accumulation of fluid or blood in the peritoneum. So all these are the things you look out for during inspection. So the next aspect of the examination is palpation. You feel gently, then you feel deeply. So we have two parts. We have the light palpation and the deep palpation. And This palpation is done over the 9 regions of the abdomen. So you do your light palpation over the 9 regions of the abdomen, then you also perform the deep palpation over the 9 regions of the abdomen. You follow sequentially. Then you palpate particularly for the liver, the spleen, and ballot for the kidneys. So for light palpation, it is done over the 9 regions of the abdomen, usually to detect tenderness. What is tenderness? Tenderness is pain on exertion, and this is usually as a result of an inflammatory condition. So eliciting tenderness in any region of the abdomen can be a pointer to a possible differential diagnosis. Hence, it is important to note where the tenderness was elicited. When you elicit tenderness in the right hypochondrium, where the liver and the gallbladder are located, you're going to have a possible hepatitis or cholecystitis as your differential, which is inflammation of the liver and inflammation of the gallbladder. If you have tenderness in the epigastrium, where the stomach and the pancreas is located, it's going to suggest a possible gastritis, peptic ulcer disease, or pancreatitis. So that sequence. So the importance of the 9 regions of the abdomen cannot be overemphasized. So if you elicit tenderness in the left hypochondrium, where you have the spleen, it might be a pointer to a possible splenomegaly, a splenic infarct, or possible splenic abscess. The right lumbar, where the ascending colon, the right kidney, and the right ureter is located, it might suggest inflammation of the parenchyma of the kidney, that's pyelonephritis, or renal stones, or even colitis, or retrocecal appendicitis. So if you elicit tenderness in the umbilical region, where you have the small intestine and the transverse colon, it might suggest a possible enteritis, intestinal obstruction, or even a para-umbilical hernia. Then if you elicit tenderness in the left lumbar region, where you have the descending colon, the left kidney, and the ureter, your differentials can be pyelonephritis or even a left renal colic. Then we also have the right iliac fossa, where you have the appendix and the cecum. So when you have tenderness in this area, your differentials can be appendicitis or Crohn's disease, which is a chronic inflammation of the intestine. We also have the suprapubic region, which has the urinary bladder, the uterus in female, and the sigmoid colon. Your differentials, a possible cystitis, bladder distension, uterine fibroid, pelvic inflammatory disease. Then lastly, we have the left iliac fossa, which contains the sigmoid colon, the ureter, and the left ovary in females. It might suggest diverticulitis, ovarian cyst, or uterine colic. So tenderness in any of these regions will be a pointer to a possible clinical condition or a diagnosis. So before you commence your light palpation, always ask your patient if he or she feels any pain at any part of the abdomen. If yes, always start away from the painful area. Then you do the painful area last. Then we have the step 2, which is the deep palpation. Here we assess for organs, organ enlargement, and mass. When you palpate any abdominal organ or mass, then you should assess for the following. You check for the size. How big is this mass? You check for the shape. Is it rounded? Is it oval? Is it rectangular? Whatever the shape is. Then you also look at the surface. Is the surface smooth? In most inflammatory conditions, the surface of the mass will be smooth. Is it nodular? In most malignancies, we find a nodular mass. Then you also look at the consistency. Is it soft? Then you check out for the consistency. Is it soft, like your lips? Or is it thin, like the tip of your nose? Or is it hard, like your forehead? Then you also check out for the contour or the edge. So is the edge of the mass regular or irregular? Or is it blunt or sharp? Then you also check for mobility. Can you get above this mass and can you get below it? Then you also check for tenderness. Does the patient feel pain when you palpate this mass? Then you also check for warmth, the differential warmth. Does the area over the mass feel warmer than other parts of the body? So for deep palpation, you should palpate deeply for any organ enlargement or any mass. Then you specifically palpate for the liver, the spleen, and then you ballot for the kidneys. So in palpating for the liver, you start from the right iliac fossa using the radial aspect of your hand and palpate upwards. The liver is usually not palpable in most individuals, but when it is palpable, you should characterize it based on the size, the surface, the consistency, the edge, as we've mentioned already. Then you go ahead to check for the liver span. The liver span is 10 to 12 cm in adults, but 6 to 8 cm in children. Then the common causes of liver enlargement includes congestive heart failure, hepatitis, amyloidosis, malignancies of the liver, such as hepatocellular carcinoma. Then we also have primary biliary disease. Then we also have storage diseases such as fatty liver disease. Then there are some pro tips I want you to keep in mind. Things that will help you make your diagnosis. If you have a smooth, tender liver, it actually indicates an acute inflammation. And this acute inflammation can be seen in acute viral or infective hepatitis. It can also be seen in alcoholic hepatitis or venous congestion of the liver, as seen in congestive cardiac failure. But if you have a smooth, non-tender liver enlargement, it suggests infiltrative or metabolic disease, not active inflammation. Some of these include fatty liver, an early phase of cirrhosis, that's a fibrosis of the liver. Then if you have a hard, irregular liver enlargement, it indicates a malignant or chronic fibrotic disease, such as primary liver cancer, that's hepatocellular carcinoma. But if the liver is moderately enlarged, firm with irregular surface and painful to touch, you should think of a liver abscess or amoebic hepatitis. Then let's move over to the spleen. The spleen enlarges downwards towards the right iliac fossa. So both the liver and the spleen palpation starts from the right iliac fossa. The spleen is usually not palpable, but it enlarges downwards and laterally towards the right iliac fossa with a notched border and moves with respiration. Some of the common causes of splenomegaly includes chronic malaria, hematologic disorders such as chronic myeloid leukemia or even lymphoma. Then we also have amyloidosis, we have malaria, we have portal hypertension as seen in chronic liver diseases. Then we also have storage diseases such as Gaucher's. Let me also give you some pro tips when you have an enlarged spleen. When you have an enlarged spleen, just like I have already mentioned, you characterize the mass. When you have an enlarged spleen, you characterize it. If you have a soft, mildly enlarged spleen that is tender, your differentials can be acute malaria or septicemia. But if you have a firm, moderately enlarged spleen that is not tender, then you think of portal hypertension. Then if you have a massive, hard, irregular spleen, then you should think of chronic myeloid leukemia. Then let's move over to the kidneys. We don't palpate for the kidneys, rather we ballot for the kidneys with the two hands. I'm going to show you how to do it in the step-by-step video. The kidneys are usually not ballotable, but in some cases, in very thin individuals, you can be able to palpate the kidney even when it is normal. Then some of the causes of kidney enlargement include cystic kidney disease, hydronephrosis, amyloidosis, pyelonephritis, or a solid renal tumor, which includes renal cell carcinoma or a lymphoma. But let me give you a pro tip for the kidney. If you have an enlarged kidney that is smooth but non-tender, your differentials may include hydronephrosis and polycystic kidney disease. Then if you have a tender, smooth kidney that is enlarged, you can think of pyelonephritis, perinephric abscess. But if you have a hard, nodular, non-tender kidney that is enlarged, then you should think of renal cell carcinoma. But if both kidneys are ballotable, which means you were able to ballot for the two kidneys, then you should think of polycystic kidney disease. Then after palpation, the next step is percussion. The abdomen is tympanic in the 9 regions. But when there is organ enlargement, such as liver or spleen enlargement, the areas over these organs will appear dull. So if there is a shift from the normal tympanic percussion note of the abdomen, it can either be due to fluid or organ enlargement. So when it is fluid, usually due to ascites, you're going to elicit for this ascites using 2 methods. We have the shifting dullness and the fluid trio. We have the shifting dullness and the fluid trio. You are not expected to do the 2 of them in every exam. So depending on the level of ascites, it will determine the one to use. But in most exams, you're expected to do shifting dullness. But when it is negative, you can now go ahead to do a flute trill. But when shifting dullness is positive, there is no point doing a flute trill. Then we are going to move over to the last part, which is auscultation. You auscultate for bowel sounds, you auscultate for brew. Then you also use it to check a special test called succussion splash. So bowel sounds are sounds due to peristaltic movement of the abdomen. It can be normoactive, hypoactive, or hyperactive. In some situations, you can have absent bowel sound. So normal bowel sound is 5 to 30 sounds in 1 minute. So you're expected to hear 5 to 30 sounds in 1 minute, and this sound is usually soft. So which means in every 5 to 10 seconds, you're expected to hear one sound. That is normal bowel sound. But for hyperactive bowel sound, usually loud, harsh, and more frequent, with more than 30 sounds in 1 minute, and it shows an increased peristalsis as seen in diarrhea or early phases of intestinal obstruction. Then we also have hypoactive bowel sound. This is faint and less frequent, usually having less than 5 sounds in 1 minute. It shows a reduced peristalsis as seen in paralytic ileus or late phase of intestinal obstruction. Then in some cases, we can also have absent bowel sound, which means no sound heard in 2 minutes. So after checking for 2 minutes, you were not able to hear any bowel sound. Then you can say that the bowel sound is absent. And this can be seen in peritonitis. Then another thing we auscultate for is for brew. These are sounds caused by turbulent blood flow through a narrowed or tortuous artery. You listen with the diaphragm of the stethoscope. So some of the brew we check for includes the renal brew, the hepatic brew, and the aortic brew. So for the renal brew, you place the stethoscope 1 to 2 cm above and lateral to the umbilicus on both sides. Then you ask the patient to hold their breath briefly, just to reduce bowel movement and bowel sound interference. Then a renal brew suggests renal artery stenosis or any other vascular abnormality such as renal artery aneurysm. Then we also check for hepatic brew. You listen over the right hypochondrium just below the costal margin. You use light pressure to avoid compressing the vessels. Then the last brew we will check for is aortic brew. You place the stethoscope just above the umbilicus along the midline. Then you listen for a harsh systolic murmur radiating laterally. It is usually best heard when the patient breathes out and holds the breath. Aortic brew suggests aortic aneurysm. Lastly, you check for succussion splash. This is used to detect gas and fluid in a distended stomach, usually due to gastric outlet obstruction, as seen in pyloric stenosis or carcinoma of the pylorus. Lastly, we are going to be talking about digital rectal examination, and I told you is the last part of the abdominal system exam. In this part, you expose the anal region, then you inspect. You're inspecting for the anal hygiene, anal feature, any skin tags, or even a rectal prolapse. Then after the inspection, you put on the gloves and apply a KY jelly. We usually use the index finger, but in children, you use the little finger. Then in neonates, you can actually use the cover of a syringe, something that can easily pass through the anus. So during digital rectal examination, you gently enter the anus, checking for the anal tone. Then while you enter, you check for the surrounding walls. If there is any tear, any laceration, or any outgrowth, then you also check for the physics. Can you feel the physics in the rectum? Is it well formed? Is it hard or is it soft? Then when you bring out the examining finger, you also check whether it is stained with physics or whether it is stained with blood, as the case may be. So after that, you clean up the patient and cover up the patient. If you're still watching, kindly hit the like and the subscribe button. The next phase of the exam is going to be a step-by-step examination of the abdomen. Okay, welcome to the practical aspect of this class, where we're going to be showing the step-by-step abdominal examination, and we're still going to follow the pre-exam, exam, and the post-exam format. So in the pre-exam, we are going to greet our patient, take consent, explain the procedure to the patient, properly position the patient, and ask for screen and chaperone, and then wash your hands and commence. So let's go. Good afternoon, sir.
Hello, good afternoon.
I'm Dr. Pascal, and I'm here to carry out abdominal examination on you, which might involve me touching some parts of your body. Can I go on?
All right.
Thank you. Then I'll ask for screen and for chaperone. Then I'll wash my hands. Please, sir, can you lie down? So I would like to expose my patient from below the nipple line to the mid thigh. But for modesty, we are going to just expose up to the pubic symphysis. So please, sir, can you? Okay, thank you. So inspection, we are going to just generally look at the abdomen of this patient and check for the shape, the symmetry, any scar, the male hairline, the umbilicus. You just generally look at the abdomen. Then you squat at the side of the bed. This is showmanship, so you always follow each step one after the other. You squat at the end of the bed. Then you ask the patient to cough. This is to elicit any possible herniation. Please, sir, can you face the other side and cough? Okay, thank you. Then you go on to check for the abdominal gate. This is usually done in abdominal distension. In this patient, there is no abdominal distension, but for the purpose of this examination, I'll just show you how to check for abdominal gate. So first of all, you find the landmark, which is the xiphisternum. You palpate for the xiphisternum. So once you get the xiphisternum, you're going to use it as a landmark for the widest diameter of the abdominal distension. So since we've gotten the xiphisternum, you measure from the xiphisternum to the widest diameter, which is around the umbilicus. Then you now measure around the patient. Ensure that the tape is at the widest diameter. So the abdominal gate in this patient is 94 cm, 12 cm from the xiphisternum. That is how to check for the abdominal gate. Then the next aspect of this exam is palpation. You always ask your patient, are you feeling any pain anywhere? So if the patient is feeling pain, you start away from where the patient is feeling pain. But in this case, the patient is not feeling pain, so you can start anywhere and follow orderly. So you superficially palpate the 9 regions of the abdomen, eliciting for tenderness in these regions. So after the light palpation, you move over to the deep palpation. For some people, they use the 2 hands. For some people, you can also use 1 hand while placing the other hand on the body of the patient. Then you go deeper. Following the sequence, the 9 regions. So after palpating for the 9 regions, you're going to palpate specifically for the liver, the spleen, and then you ballot for the kidney. You palpate for the liver, starting from the right iliac fossa and move upwards. Then you ask your patient to breathe in, sir, out. You check for the liver span. You percuss from the right iliac fossa upwards till you feel the hepatic dullness. At the point where you feel the hepatic dullness, you ask your patient to place his finger at that point. Then you move over to check for the second intercostal space and palpate downwards until you feel the hepatic dullness. Then you measure the distance where you felt the dullness. Please, sir, can you place your hand here? Just 1 finger at this point. Then you palpate for the sternal angle, which translates to the second intercostal space. Then you palpate downwards. You palpate in the intercostal spaces. Then you measure the distance between this area of dullness. Okay, in this patient, the liver span is 10 cm, which is normal. Then we'll go over to the spleen, palpating for the spleen. The spleen enlarges downwards towards the right iliac fossa. So we'll palpate obliquely towards the left. Please, breathe in, out. Then you ballot for the kidneys. You ballot for the kidneys, placing your right hand over the right lumbar area, and you ballot with the left hand. You ballot this way. The same thing applies to the left side. The same way, place the right hand on top and ballot with the left. Okay, that is that for palpation. Then we are now going to go over to percussion. Percussion, you're percussing on the 9 regions of the abdomen. Then you're going to elicit for possible ascites doing a flute trill or a shifting dullness. You're expected to hear a tympanic percussion note over the 9 regions of the abdomen. But in cases of ascites, you're expected to do a shifting dullness or a flute trill. So for shifting dullness, you percuss from the center to the side. Then once you get to the side, you ask the patient to roll over and then you wait for 30 seconds to 1 minute to see if the percussion notes on that area will change. Sir, please can you just then you wait for 30 seconds to 1 minute and then you percuss again. So the percussion note is still the same, which means in this case there is no ascites. So in most cases, after doing shifting dullness and it is positive, there is no need doing a flute trill. But if the shifting dullness is negative, then you're expected to do a flute trill. And flute trill is done to check the transmission of waves from one part of the abdomen to the other, and usually done when there is massive ascites. So you tell the patient to use one of the hands to depress the center. Just depress here. To depress the center while you place one hand on this side and you tap the other side. So in cases of flute trill, you're expected to feel a push of fluid or a splash of fluid on this other hand. So you just hit this way. So you're expected to feel the movement of fluid touching your palm on this side. So after that, you can now go over to auscultation. So in auscultation, we are checking for the Bowel sounds, hepatic brew, renal brew, and also for aortic brew. So for the Bowel sound, you're going to listen for 1 minute. And you're going to listen at the McBurney's point. The McBurney's point is a point between the umbilicus and the anterior superior iliac spine. This point is 2/3 away from the umbilicus and 1/3 away from the anterior superior iliac spine when you draw an imaginary line along that axis. So you're expected to hear 5 to 30 sounds in 1 minute for a normal Bowel sound. Then after that, we are going to check for aortic brew by placing the diaphragm of the stethoscope above the umbilicus. You're also meant to check for renal brew. Renal brew is checked on the lateral aspects of the umbilicus, 1 cm above and lateral. So on both sides, you check, and you check on this side too. Then on the area over the liver, you check for hepatic brew. So lastly, we are going to actually elicit for succussion splash. Succussion splash is done in gastric outlet obstruction. You place the diaphragm of the stethoscope at the epigastric region and you move the abdomen from side to side. You're expected to hear a whooshing sound at the epigastric region, which shows gastric outlet obstruction seen in pyloric stenosis and so on. Then lastly, you are meant to do a digital rectal examination on your patient. That concludes the abdominal examination. So after the exam, you're expected to thank your patient and summarize your findings. Thank you so much, sir. So in the next video, we are going to do a 3-minute OSCE scenario. After that, I will now summarize my findings.